So preventing a second stroke is vital. Our key recommendation is, as far as non-cardioembolic strokes, is that patients must be treated with an antiplatelet agent. Again, I said the selection is probably less important than the fact that you start it, and you start it today. And when we look at that EXPRESS study and try and figure out which elements in that EXPRESS study led to that dramatic 80% reduction in stroke risk, it was the combination of little things like starting the antiplatelet agent aggressively right at the beginning, right after their symptoms, doing everything early rather than any specific one element. So atrial fibrillation, as Ron mentioned, this causes severe strokes. And on our stroke ward at the Vancouver Hospital where I work, every day we round, the ward is filled with the carnage of devastating strokes due to atrial fibrillation. 60% of these strokes are disabling, 20% are fatal. Atrial fibrillation is currently the worst disease we have in the cerebral vascular system. It causes big, bad, disabling strokes in elderly patients. And we have effective stroke prevention strategies, but we underutilize them. If we use warfarin, and there'll be new agents coming along in an effective fashion, we can reduce the risk of stroke by about 2/3. We can reduce the risk of death by about 1/4. It is highly effective. It's a fussy medication, but it is our best agent at the present time. There are new agents coming, and we may get to that in the question period. There are new anticoagulants that have several advantages and benefits over warfarin therapy. So for stroke prevention, aspirin, clopidogrel, or the combination of extended release aspirin plus dipyridamole are all acceptable for either primary, well, not for primary, for secondary stroke prevention. These are patients who've had a TI or stroke. A common question that comes up is, should we be using the combination of aspirin and clopidogrel? And the answer to that is we don't recommend this treatment for long-term stroke prevention unless there's a specific indication. And the most common indication right now for long-term use of this combination of drug would be drug-eluting coronary artery stents, in which they have to be on aspirin and clopidogrel for usually at least a year. Prevention of medical complications. When do we... Two more slides, okay. The prevention of medical complications post-stroke, this is going to be looked after by good care on a stroke unit. There are a variety of problems that occur following stroke. Depression is very underestimated, underappreciated following stroke. Post-stroke depression is part of the stroke syndrome. It's treatable. If you don't treat it, it delays recovery and it impedes rehabilitation. So look for depression in patients. We've talked about the assessing for dysphagia and swallowing tests. Pneumonia is one of the most common causes of death following a stroke, and aspiration pneumonia is probably the most common cause of that. Of course, good skin care is important. Physiotherapy to look after shoulder pain, and DVT prophylaxis is part of standard hospital stroke care. The key thing to improving functional outcome besides aggressive physiotherapy is really early mobilization. I'd like to see the patients up and in a chair and dangling and moving as quickly as possible. All too often patients are left lying in a bed with a catheter in, which is just the reverse of what we should be doing. So I'd encourage everyone, as they're making rounds on stroke patients, is to keep pushing the mobilization order forward. I'm going to turn the podium back over to Ron here. Thank you.
Thank you, Phil.
Ron, it's Mark. Just a quick cue that we've got about 5 minutes left before we move into questions and answers. Thank you.
We will be less than 5 minutes. Thank you, Mark. Just want to quickly cover the last two recommendations for you and then review them all. Assess all stroke patients for their rehabilitation needs. This is key recommendation number 6. May seem like a motherhood issue, but doesn't always occur. And we want to emphasize that management on a rehabilitation unit does improve functional outcomes that are durable for up to 1 year, and that all patients admitted to hospital should be assessed as soon as possible by a rehabilitation professional. If patients are not admitted, if they have a mild stroke, then they should have a referral for a rehabilitation assessment within 2 weeks. There are some stroke patients who are not admitted nowadays, but that's rare. The seventh and last recommendation, and this involves communication. In this day and age when there are more and more hospitalist physicians, when less, in the urban center at least, less family physicians are attending their patients in hospital, it's very critical that timely communication go back to the family physician so they can continue the ongoing management of these patients. So make sure that communication occurs in a timely way. In the appendix of this stroke guideline, there are forms that can be used for TIA patient discharges or TIA and stroke summaries with all the pertinent information going back to the attending family physician. There are some obstacles to carrying out even these 7 guidelines. We realize there are geographic barriers in some areas of the province. There is access problems to urgent carotid ultrasounds or angios, TPA, CTs, defined stroke units, and rehabilitation services. However, progress is being made, and hopefully with the publication of this guideline, more progress will be made. Certainly, heart and stroke, along with the government and the regions, have made great progress in the last while towards improving access with the development of the TIA and stroke rapid access clinics, with the development of the TPA and stroke management protocols in all the emergency wards, with the institution of telestroke, which has come on board just as we speak over the last month in some areas of the province, whereby there is audio and visual links from the emergency department to attending neurologists, especially those here at Vancouver General Hospital, for the management of the patients and hopefully to optimize the utilization of TPA, and by education of healthcare providers and patients. Other useful guideline contents, just quickly touch on those. Those are in the appendix. Medication table is very useful, has monthly costs and pharmacare coverage, and there is an excellent handout, 2-page handout that can be used for patient education. And those are all available online at bcguidelines.ca. So in summary, let's just review those 7 key recommendations again. Treat emergent TIAs as a medical emergency with investigations completed and treatment initiated within 24 hours of onset of the patient's symptoms. Give antiplatelet therapy to all non-cardioembolic TIA and ischemic stroke patients unless contraindicated. Assess all stroke patients for TPA as soon as possible. Remember that time is brain. Manage on a designated stroke unit. That's associated with better functional outcomes. And in smaller hospitals, at least manage on a consistent ward where the team can get educated and have a consistent approach to stroke patients. Consider all patients with atrial fibrillation for antithrombotic therapy. Use your CHADS-2 score. Assess all stroke patients for their rehabilitation needs. And finally, communicate in a timely way to family physicians after an emergency or inpatient discharge for TIA and stroke. So with that, we'll turn it back to Mark for moderating the question period. Thank you.